Once denervation has occurred, individual muscle fibers begin to behave abnormally on their own, generating spontaneous electrical activity without any nerve signal driving them. This spontaneous activity comes in two forms, each with a different scale and a different clinical meaning. Fasciculations occur when an entire motor unit, meaning all the muscle fibers belonging to one motor neuron, fires spontaneously as a group. Because multiple fibers contract together, this generates enough mechanical force to produce a visible twitch beneath the skin surface that the examiner can see directly without any equipment. Fasciculations are a hallmark sign of lower motor neuron or axon pathology. Fibrillations occur at a much smaller scale, individual single muscle fibers firing spontaneously on their own, completely independent of any motor nerve signal. Because only one fiber contracts at a time, the movement is far too small to see with the naked eye. Fibrillations are detected only with electromyography, a needle study that measures the electrical activity of individual muscle fibers. On EMG, they appear as low-amplitude, regular spontaneous potentials. A critical diagnostic point about timing: fibrillations do not appear immediately after nerve injury. They typically emerge 7 to 21 days after damage has occurred. This delay reflects the time required for the distal axon stump to undergo Wallerian degeneration and for individual muscle fibers to develop the membrane instability that drives spontaneous firing. The presence of fibrillations on EMG therefore tells the clinician not only that lower motor neuron injury has occurred, but that it happened at minimum 1 to 3 weeks ago, providing a biological timestamp for the injury that carries real diagnostic value. In summary, on-needle EMG, fasciculation potentials are spontaneously firing motor unit potentials. Clinically, fasciculations are small involuntary contractions from spontaneous discharge of a single motor unit, and usually signify lower motor neuron denervation when seen in the appropriate context. Fibrillation potentials typically fire regularly, may appear as spike or positive wave morphologies, and indicate denervated or actively denervating muscle fibers. They are nonspecific and can occur in neuropathic and some myopathic disorders. After acute nerve injury, distal conduction may persist until Wallerian degeneration occurs over about 72 hours, while fibrillation potentials/positive sharp waves usually appear only after about 10 to 14 days. Some sources note a broader 1 to 4 week window depending on lesion to muscle distance. For peripheral nerve injury, EMG is generally more informative after at least 10 to 14 days, and one surgical text recommends waiting about 3 weeks after a closed injury for the first study to help distinguish neuropraxic from more severe axonal injury.